Welcome to the deep dive. In medicine, there's this powerful instinct, right? That if one thing is good, two things must be better.
Especially with something like antiplatelet drugs.
Exactly. And today we're diving into some research that really pushes back on that assumption. We're looking at patients recovering from coronary artery bypass surgery, a CAIB.
And not just any CABG patients. These are people who had the surgery because of an acute coronary syndrome. So, a recent heart attack.
These are some of the highest risk patients out there. They're on a razor's edge and they absolutely need protection from future clots.
And our source for this deep dive gives us a really clear answer on how to do that. We're breaking down a major new article from the NEJM. It's titled Ticagrelor and Aspirin, or aspirin-alone, after coronary surgery for acute coronary syndrome.
Oh, okay, so a big trial.
Oh, it was massive. A registry-based trial across 22 different surgery centers in the Nordic countries. So this is real-world data.
So let's just frame the big question here for everyone. After this major heart surgery, do you stick with the standard just aspirin, or do you go for the 1-2 punch, adding a stronger drug like ticagrelor?
Right. Does that extra firepower actually help? Or does it just introduce, new risks?
That's the mission today. Let's figure out the real cost benefit of more protection.
Okay.
So let's set the clinical stage a bit. The whole idea behind antiplatelet drugs, aspirin, ticagrelor, is to stop blood platelets from clumping together.
To stop clots from forming that could cause another heart attack or a stroke.
And we know for a fact that patients who've just had a heart attack are at a huge risk for another one. So giving them some kind of antiplatelet therapy after surgery is, it's not even a question. It's essential.
It's absolutely essential. And, in a lot of modern cardiology, especially when a patient gets a stent instead of bypass surgery, dual antiplatelet therapy, we call it DAPT, is the standard of care.
Right. Aspirin plus another drug.
Exactly. And it works really well after stenting. The thinking is you've got this foreign body, this metal stent, in a vulnerable artery, so you need maximum protection.
So the idea behind this trial was basically to ask, hey, does that same logic apply here?
That's it, exactly. Does the success we see with DAPT after stenting translate to patients who got bypass surgery instead? Protecting those new grafts is, it's absolutely critical.
And this trial, you said it was huge. So who exactly were they looking at?
So they enrolled 2,201 patients. All of them had a CABG, specifically because of an acute coronary syndrome.
Okay, so a very focused group.
Very. And they were randomized 1-to-1. So 1,104 patients got the combination therapy ticagrelor plus aspirin.
And the other half?
The other 1097 just got aspirin by itself, out of control group.
And what did the typical patient look like?
Pretty much what you expect. The mean age was 66.
Yeah.
And they were followed for 1 full year, which is a great time frame.
And the fact that it was registry-based, pulling from routine care at all those centers, that has a lot of weight. This isn't some super controlled artificial environment.
It's what's actually happening in hospitals.
So before we get to the results, what were they measuring? How did they define success or failure?
Okay, so 2 main things to watch. First is the primary outcome. This is the efficacy measure. It's a composite of 4 things: death, myocardial infarction, so another heart attack,
Am I right?
stroke, or repeat revascularization, which just means needing another procedure to open up an artery.
That's the classic combo for a cardiology trial. But you said there were 2 measures?
Yes, and the second one is just as important. It's called Net Adverse Clinical Events, or NACE.
NACE. Okay, what's next?
It's everything in the primary outcome: death, MI, stroke, revascularization, but you add one more thing: major bleeding.
Ah, so it's a balance of efficacy and safety.
Precisely. Any blood thinner powerful enough to prevent clots also carries a risk of causing a bleed. NACE gives you the full picture. Did the treatment help more than it hurt?
All right, let's get right to the findings, because this is where that whole more is better idea just runs into a brick wall.
It really does. The expectation going in was pretty clear. You'd think adding a second very potent antiplatelet drug would have to give you some kind of an edge.
Of course.
Yeah.
But the results?
No, nothing. There was absolutely no statistically significant benefit in the combination group when it came to that primary outcome.
Wait, hold on. You add this powerful drug and the rate of heart attacks, strokes, and death is the same.
Pretty much identical. It was, I think, a real surprise. For a population this high risk, you would expect the stronger regimen to show some kind of advantage, but the protective benefits were a complete wash.
Okay, let's get into the specific numbers. I think that really tells the story.
For sure. So in the group that got both ticagrelor and aspirin, 53 patients had a primary outcome event. That comes out to 4.8% of the group.
Okay, 4.8%. And what about the group that only got aspirin?
50 patients, which is 4.6%.
Wow, okay, 4.8% versus 4.6%.
Yeah.
That's nothing. That's a rounding error.
It's functionally the same.
Yeah.
And the statistics confirmed it. The hazard ratio was 1.06. A ratio of 1.0 means zero difference, so 1.06 is clinically meaningless.
And the p-value, that's the real test, right?
The p-value is 0.77.
0.77. So for anyone listening, a p-value needs to be below 0.05 to be considered statistically significant. 0.77 means that tiny difference they saw was almost certainly just random chance.
Exactly. Just statistical noise.
So the first big takeaway is crystal clear. The whole hypothesis that dual therapy would be better at preventing heart attacks and strokes after CABG, it was completely wrong. The data just wasn't there.
Which brings us to the other side of the coin, the arguably more important part of this.
Right. Okay, so if the combination therapy didn't help, the next logical question is, did it hurt?
And that's the pivot. You never use a potent blood thinner for free. There's always a risk. Since we saw zero efficacy benefit, we have to look very, very closely at the safety.
Specifically, the bleeding risk.
And this is where the results go from just being surprising to being really, really important for doctors and patients. The rate of major bleeding was substantially higher in the combination group.
How much higher are we talking?
Let's look at the numbers. In the ticagrelor plus aspirin group, 4.9% of patients had a major bleed.
Okay, 4.9%.
Now compare that to the aspirin-alone group. It was only 2.0%.
Whoa. So you're going from 2% to almost 5%. You're more than doubling the risk of a serious major bleed.
It's a massive difference.
Yeah.
And you have to remember who these patients are. They've just had major open heart surgery. A major bleed for them isn't a small thing. It could be catastrophic.
It could mean going back to the hospital, needing blood transfusions, maybe even another procedure. It completely derails their recovery.
It can be devastating. These are life-altering, sometimes life-ending events.
So how did the study quantify that risk? I know they used the hazard ratio for that too.
They did. And this is the number that should really stick with you. The hazard ratio for major bleeding was 2.50.
2.5. So what you're saying is the group on 2 drugs had 2.5 times the risk of a major bleed compared to the group on just aspirin.
2.5 times the risk for zero benefit.
That is a terrible trade-off.
It's an awful trade-off. And that's what drives that secondary outcome, the NEJM. Remember, NEJM combines the heart attacks and strokes with the major bleeding.
Right, the total picture of harm versus help.
And when you factor in that huge increase in bleeding, the overall picture for the combo therapy gets even worse.
So what were the final NACE numbers?
The NACE rate in the ticagrelor plus aspirin group shot up to 9.1%.
Okay, 9.1%. And in the aspirin-alone group?
It stayed much lower at 6.4%.
So by trying to prevent that 4.8% of cardiac events, which it failed to do, they actually ended up causing a total of 9.1% of net adverse events.
Exactly. The final hazard ratio for NACE was 1.45. It just confirms that the treatment was, on the whole, worse for the patient. The safety risk completely overwhelmed any potential benefit.
So, when you put it all together, this deep dive leads to a pretty powerful and I think a very definitive conclusion.
It really does.
For patients who have a CABG because of a heart attack, using ticagrelor on top of aspirin was no better than just using aspirin alone at preventing death, another heart attack, or a stroke at 1 year. Full stop.
And the big takeaway from that is just so clear. This study gives us really strong evidence that in this specific group of patients post-surgery, the benefits of dual antiplatelet therapy just do not outweigh the huge, significant increase in bleeding risk.
We're talking a 250% increase in major bleeding.
An enormous safety cost for no benefit. It's just a crucial lesson in that balance between efficacy and safety.
It also kind of makes you feel more confident about just using plain old aspirin in these patients, right?
It does. It confirms that it's an effective and much safer choice for this population. And it forces you to think about the real differences between getting a stent versus getting bypass surgery.
That's a great point. With the stent, DAPT is king. But here,
it seems like the bypass surgery itself creates a different biological situation. Maybe those new vessels are just less prone to the kind of clotting that DAPT is designed to prevent.
that's really fascinating. And it leaves us with a provocative thought to end on, something for you to mull over. We know from the source that these patients need some kind of antiplatelet therapy. This study shows that adding ticagrelor doesn't help and, in fact, causes harm. So the question is, how does this change things? Does it mean we should be thinking about the duration of therapy? Or maybe there's some tiny ultra-high-risk subgroup where this still makes sense? Or maybe, and this is what I'm leaning towards, maybe the surgery itself is just so protective that for most of these patients, simpler really is better.